Great.
Hello, my name is Becky Sanders, and I'd like to welcome you to the Upper Midwest Telehealth Resource Center webinar. Today, we're going to hear from Michelle Hager. And before I really introduce her and hand things over, I want to just do some housekeeping. We are recording today's session. It will be on our YouTube page. We'll also have the slides from the presentation posted on our website with the link to the YouTube page. If you have questions throughout the presentation, you can use the Q&A function at the bottom of the screen to ask questions. The chat, we would really like that reserved if you have a specific technical issue, and you would send that to Carolyn Miller, who's doing our recording and hosting the webinar today. So without further ado, I would like to introduce you to Michelle. And Michelle and I met a couple of years ago when we did our inaugural UMTRC conference in July of 2019, which actually was held in person. And she had an awesome presentation on the Justice League. And we talked throughout the conference about our telehealth champions. So Michelle, I'll hand it over to you.
Thank you so much, Becky, and thank you to the UMTRC for inviting me to come and speak today. Really appreciate it, and appreciate everyone who's here to listen. So if you've been to a presentation of mine, as Becky mentioned, we always have a theme, and that was the Justice League before, but today it's picnics and ants, because you can't have a picnic without some ants. We're going to talk a little bit about reimbursement and quality. So having a quality program, you still have to have some revenue associated with it. So we're going to talk about revenue and reimbursement, as well as quality metrics and achieving the quality of care and improvement in care and access that you're looking for with your programs, and how to measure that over the course of your program terms so that you have a successful and sustainable program. So one of the things I wanted to talk about is, of course, what's on the mind. First of all, it's level set on COVID. So we know that telehealth has caused an exponential increase in the amount of visits that we've seen over the course of the COVID public health emergency, 50% increase overall in primary care visits. And what's interesting on this slide, and what I wanted you to kind of draw your attention to, is the typical the typical conservative AMA has actually said 20% of visits in the ER. This can reduce the number of visits to the ER. We can do 35% of home health visits can be virtualized, 24% of outpatient visits could be virtual, and then they're claiming that 2% of outpatient visits could be shifted to a home setting. I think probably more than 2% could be shifted to a home setting, but that is in fact, the AMA defining that, which has historically been fairly conservative related to telehealth in general. And what we're typically seeing from a patient perspective, and those that are in the home, obviously with COVID, having the relaxation of some of the restrictions related to telehealth, we're seeing them landing around 25 to 30%, depending on the organization. So if you're wondering, where's the bottom, where's the top? It's typically around that 25% number for total visits, of total visits, 25% being telehealth. Patient adoption statistics, as we talked about, have been exponential. This is only through March. 52% have finally said that they've done a first-time telehealth visit. You probably know this, you're living this every single day, but as I said, you may want to know, where is this going to land? Where's the bottom of this or the top of this? Somewhere around that 25% mark. And this is only through April. So even normally the data 6 months ago would be perfectly satisfactory. So we'll have to see what the next couple of months looks like in terms of the surveys for telemedicine users and what the users have and patients have done over the last 6 months. The market growth has been incredible. We have investment by venture capitalists across the globe. In particular, the North American market is the highest. As you can see, it's at $21.2 billion. And our global market is in the multiple billions of dollars, as you can say, higher than that, 50 to 100. I think when my last global market trend was somewhere in the neighborhood of $260 billion. Actually, there's our telehealth market from the global perspective in the top left. It's good for me to not have to remember that. So I've got 266 billion projected to be in 2026. So just 5 or 6 years from now. So incredible growth, incredible investment. What does that mean? That has major pressures in the market. We know that venture capital funding has gone to multiple direct-to-consumer products across the spectrum. Some of these you may know, some you may not. And in addition, they've had even more funding. And this slide was updated just 6 weeks ago. So we've seen even more funding happening in this space in the last, even couple of months. There will be even more compression in the market. That means that there is more difficult, with all this investment, there's more difficult choices for you as the consumers of those software and hardware solutions. However, the market will continue to compress. They will continue to purchase other companies. We will see more mergers, acquisitions, and perhaps even some companies into the market that we aren't even aware of today. We know that Amazon, for example, has just stepped their toe into the pharmacy space, but they do have designs to move even further than that. We know that the real estate market will continue to compress with healthcare. With all of us working remotely, people have found that you don't necessarily need to be in an office. IT, for example, was already off campus. How much further can they be? Can they be at home rather than being 2 miles away from the office? And there will be even more resource compression with remote work. Can we do more with less? Industry mergers, consolidations of services across the industry. So look for more compression as we come into 2021. But in the rural America, in the rural health space, this telehealth challenge is felt even greater than anywhere else. Only 11% of physicians practice in rural areas, despite having 20% of the US population in a rural area. And they're more likely, Americans are more likely to die prematurely from the leading 5 causes of death in rural America. So we know that telehealth improves the monitoring and timeliness of communication. We know that this provides for fewer patients to be transferred. We know that it allows smaller hospitals to keep those patients, not have to transfer them, and elevate their practice to be able to provide more care for patients in those rural spaces. And of course, as always, it minimizes the patient travel. So high patient satisfier from that perspective, particularly in rural America, and also accessing the specialists that they may not have access to today. As we've talked about, the top 5 chronic illnesses, rural America is more likely to die. They're older in rural America, they're sicker, populations are growing in the rural area only because, are reducing in the, populations are reducing in the rural areas, but they're getting older. So we'll see counties reducing population, but the age of the patients and the age of the population is getting older. So those are sicker, more chronic disease. So across rural America, they're older, they're sicker, and they're poorer, which means that telehealth is even more challenged to get to those patients where it's the most helpful to them. And we know that almost 14% of rural population live below the poverty line. So that gives us some challenges in trying to access them from smartphones where they may not have a smartphone, or if they do have one, they don't want you to use their data. This slide is a little bit blurry, but one thing I wanted to point out to you is at the very bottom, the broadband access. This is a challenge that we see across America in rural America. Obviously, those cable companies, those broadband companies, they don't make any money going to the 25 people or 50 families that may be living in a particular rural area. And so they don't bring that broadband to that area. We need to encourage that. The FCC is trying to encourage that. There are ways to extend your services, and we'll talk about that a little bit later. That's a huge challenge to be able to reach them, and it was definitely noticed when we started to do school-based virtual school, because students, had to try to get to school virtually, and we noted that how many of those patients didn't even have broadband access. And in my state, for example, they had to close the virtual option. They had to go 100% paper because so many students do not have access to broadband in a particular area of the state. Across the country, we know from Fair Health data, which is a great place to look for data. This represents over 32 billion claims filed across the country. Across the nation, we've seen the volume of telehealth claims increase from virtually nothing in September of 2019 to over 5% of total claim lines in 2020. And this is up till September of 2020. What's interesting is the top 5 procedure codes, both in 2019 and in 2020. In 2020, we see the established patient office visit, typically about 50 minutes. But what's number 2? Psychotherapy at 60 minutes. Behavioral health has been over and over again shown to be a high value in the pandemic and also across telehealth. And I think that's going to continue into 2021. We see that both in 2019 at the bottom, top 5 diagnoses. In September of 2019, we saw behavioral health conditions and acute respiratory diseases, et cetera, like flu, pneumonia in 2019. And in 2020, what we see is mental health conditions and joint or soft tissue diseases. We don't even see the acute respiratory diseases until we get to the 4th one, and the number's 2% compared to 2019. So obviously our social distancing is making a difference there, but patients are utilizing telehealth for mental health. That is, we're seeing lots and lots of claims being utilized for that. We're also seeing patients being utilizing, or clinicians utilizing telehealth for abuse cases and sexual abuse or other types of domestic violence. Or you'd be able to utilize and access specialists who are used to looking at those types of injuries, and they're able to diagnose those patients even better through telehealth. So another reason to utilize at one point there, if the patients are victims of child pornography, we don't utilize telehealth in those spaces. Obviously, we're using a camera and they were victimized with a camera. So trying to avoid and not utilize that with those patients. But interesting to see what Fair Health is documenting across the country, and then rural versus urban as well. And in your region, in the Midwest region, this is covering a lot more states than what the UMTRC covers, but it does give you a good idea of what you're seeing, and it's very similar. I'm just going to slide back to the national. So from a national perspective, local perspective, very close in your data. And also you can see the top 5 procedure codes there at the top from 2019 to 2020. Psychotherapy, again, top of the list, outpatient visits being second in that list, and then established visits for about 25 minutes being third. But then our 4th one is psychotherapy again. So you can see how these procedure codes and claims are being filed across the nation and in your region, and what your other folks are doing in other parts of the country. But we do have to have both a hard ROI and actual reimbursement for services to be able to sustain programs. And what the public health emergency has done with the waivers is waived away some of the challenges that we saw. But that's not, sort of Glenda the Good Witch waving away the, Wicked Witch of the West. We're going to see that resurge. We're going to see some of those changes resurge back. So we need to find where our reimbursement is going to be. There is big effort from CMS and on Capitol Hill to get more reimbursement for telehealth services, but we also want to look at our quality improvements. So again, we can't have ants, we can't have a picnic without ants, right? So our quality improvements are those labor efficiencies, and capacity building. Where's our provider and patient satisfaction, and how can we improve on our existing quality metrics that we are currently defining and currently measuring. So when you're doing that, measuring your actual face-to-face visit and comparing that against a telehealth visit, you should be able to get as good or better in those quality measures. We know that CMS is driving towards a value-based system, or they're driving even further towards value-based care. We know from their recent chart, CHIRT, they're seeing scenario 1, quality improved, cost neutral. Scenario 2, quality neutral, cost reduced. But the most favorable is the one they want. Quality improves and cost reduce. So we know that they're driving towards improved value-based care. We're looking at reducing cost of care, et cetera, over the course of the next coming years. And so ACOs, other value-based contracts will be very important in the next year or two. So those value-based contracts right now, based on their payment goal system, are in two different buckets, both direct contracting and primary care first. So this is where CMS is heading to. So for direct contracting, we know we have geographic, global, and professional types of contracting that we can do, both where the organization is responsible for the total cost of care for a defined particular population. They can bear full risk under a global, or you can do optional share with some financial risk with CMS. Versus primary care first, you are incentivizing the provider to reduce the cost of hospital utilization and total cost of care. And then obviously for our high need population, that's where we're driving to. So this was CMS data as of January 1st, 2020. There were over 517 shared saving programs or ACOs with over 17,000 participants. Now, I will say that CMS is questioning the ACO model and the value-based care risk share models. So they're trying to see if they're getting as much as they expected from those programs, and there's some auditing being done with that, but even still, they're still driving towards value-based care, and lots of reasons why telehealth is a great utilizer in a value-based care system. We recently saw the physician fee schedule change. This is about 4 or 5 high top topics that we saw coming out of the physician fee schedule. I have also included an article that Foley and Laudner did. They do a good job with identifying telehealth law and the things that are happening and keeping track of Medicare laws. So if you aren't following them on social media, and then you should, they do a good job of defining the changes with CMS. But these top 4, direct supervision with telehealth for nurse practitioners, this is a big one, right? For nurse practitioners that were being supervised, they could not do it without them being directly in the room. And obviously with social distancing, or directly in the building without social distancing, couldn't happen. Or in my state in South Carolina, where we have barrier islands, sometimes nurse practitioners are the only ones that are taking care of those patients with the docs off the island. So if they retire, or if they're not available, that makes a huge difference for those patients that are out on the islands, not be able to reach them. So I'm sure that there are lots of rural areas where this is true in your region as well. So being able to do supervision of nurse practitioners via telehealth, huge improvement. We know that audio only assessment services have been made permanent. These are virtual check-ins via the phone, so G2252. And then a crosswalk when you need additional complexity with the patient, you have a CPT code as well to crosswalk to that more complex visit. And then obviously for these, geographic location restrictions do not apply. So that's a really great one when you're doing telephone visits. You can do those from home, etc. If you are in a nursing home, we have had frequency limitations for nursing home visits via telehealth once every 30 days. Now it's being shifted that you can do it once every 14 days. So more frequently, less limitation in terms of the time frame that you can do a visit via telehealth. So good improvements in the physician fee schedule. And then new practitioners, those that currently don't bill E&M codes, they can do remote assessments of store and forward, including interpretation, as well as some virtual check-ins that are that 5 to 10 minute short virtual check-in. So some new practitioners added to the list. And what we see in the physician fee schedule changes that are made permanent, some of these are actually piloted. So for example, the nursing frequency change for nursing facilities, that one is a pilot where they're looking to see as well as a direct supervision that will be piloted over the course of 2021 just to see how that goes. They want to make sure that that type of supervision is going to be effective across the healthcare continuum. But there's a lot of promise here. The other codes are permanent, and that means as we see the trend for CMS is to continue to move forward with payments processes and payment systems for services via telehealth, which is good. That's moving things in the right direction. We know there are still reimbursement challenges, of course, across the country. You probably are aware of those as well in your state. You can see this is from CCHP. They do a great job, and as the TRC does as well. So please follow CCHP, your TRC, the UMTRC, as well as some of the other TRCs as well. They all consortium together, and so they provide great information and detail for you related to the reimbursement challenges, and always doing some good analysis across the country. We still have some challenges, but one thing to note is that in my state of South Carolina, even though it says we don't have a parity law, we don't have one, but we do have sort of a chill or an agreement between the hospitals and the payers that they will, in fact, pay as long as they don't try to pursue a parity law. So, for right now, there's this sort of truce, I guess, related to reimbursement challenges in telehealth. So we still have some work to do, of course, in reimbursement. That's important that we continue to advocate, we continue to talk to our legislators to show the value of telehealth. There's some big programs that are being worked on right now for data collection related to telehealth. So I'm on the advisory board for the Center for Telehealth Policy and E-Law. And the CTEL is actually gathering information from organizations and your telehealth visits so that we can show that to the Congressional Budget Office and just display to them and demonstrate to them the challenges and the improvements that we've been able to make in patient care with telehealth. So if you have an opportunity, take advantage of that and utilize your data to help improve the work that's being done at the federal level. We've seen, the slide's a little bit blurry. We've seen that legislation has been enacted over the course of the year tremendously. Not much on the broadband side, although we know that there's a lot being worked on. Representative Clyburn, the current majority whip, has legislation out there and part of an infrastructure bill for broadband to be considered part of the infrastructure, and they extend the broadband out into not only rural areas, but every area in the United States, in the same way that electricity is in every home and every area. Cross-state licensing, we've seen the medical physician compact be enacted in most states. So you see in 2019, we saw lots and lots in the physician in the cross-state licensing piece. Not as much this year, but that may be due to the progress that we saw there. Demonstrations, we see Medicaid reimbursement, slight increase in 2020. We see network adequacy just about the same, but on the private payer reimbursement, that's where we saw a huge increase in the amount of enacted legislation in 2020. So requiring private payers to pay something for telehealth. Didn't have to be parity, but at least you needed to pay something. So in many states, you're seeing some payment being enacted, not necessarily on the same level as fee-for-service, but still seeing some payment there as face-to-face, but still seeing some payment there. One thing that's important to know is that as the legislators are looking at parity payment, they're wondering if they need to do full parity or if they need to do a percentage of, because if you are not supporting a brick and mortar location and you're just doing a virtual visit, why would I need to pay you at the same rate? And for those of you that are, excuse me, for those of you that are at a hospital or health system, or even in a clinic or a rural health clinic as well, you know that you are providing the continuum of care. You are the person that is providing care to them from when they were born all the way until they die. And if you are just dealing with a virtual company, those are episodic. That's not a continuum of care. So make sure that if you have a relationship with your legislators, that you talk to them about this, how those that are providing brick and mortar care, yes, it's a little bit more expensive, and that's why you need to continue to do parity of payment, because you are providing a continuum of care versus an episodic care. And obviously, ultimately, continuum of care will be more cost effective. But this can be a heavy load. This ant carrying a strawberry on the back, this is carrying his food along with him. So it can be a heavy load for us to try to get all of our legislators on board, catch all of our fee for service. So Let's talk about a couple of ways to do that. In the hard ROI reimbursement, you've got the opportunity for fee-for-service payment right now, of course, and certainly with the PHE, you've got more opportunity to do that. But also look at bundled payment structures for where you have bundled payments. The telehealth is a great opportunity. You're not going to get more money for that particular service. So how can you drive cost out of it? And telehealth is a great way to drive cost. And it doesn't have to be expensive. You don't have to purchase big expensive systems with fancy names and all of that kind of stuff. You can just do something with a tablet and an IV pole, or providing tablets to people. Things can be very simple, very inexpensive. You can also contract with other facilities if you have excess clinical opportunities. So for example, if you happen to have a wound care specialist in your clinic or in your hospital, in your health system, and they have some extra capacity, you can actually bill your services and contract your services to other people who don't have those wound care services. You can also have downstream revenue from those contracts. You can also do some grant funding to do some startups. We just saw the final FCC grant on December 7th. Significant grant there. We'll see how that goes through. It's $100 million. It's targeted for rural areas. But we'll see what they do in 2021. We know that some monies are going to be allocated both in CARES. Let's keep our fingers crossed that we have something for CARES too. And we'll see what happens in the next administration. My friend and I, Carol Yarborough, did a presentation recently for reimbursement and billing, and she did this slide, so I want to give her credit for that, both on the inpatient side and the outpatient side, kind of looking what's going to happen during the PHE and post-PHE. So during the PHE, we know that the geographic site restrictions are waived, which is great, which means the urban areas are allowed to provide those services regardless of where they are located. And a provider, are they located within 250 feet of the main hospital? So if you're within 250 feet of the hospital, that's not considered telehealth. You aren't able to do a visit for telehealth. You need to go into the hospital and bill it as normal. And when you do bill, it's normally the same when it's doing video or telephone. It's the same as any of the billable stuff that you would do as time on the floor. Telehealth admissions are okay. You can see some of the codes there, CBT codes for the telehealth kind of initial visit codes that we see there, and then modifiers and place of service codes as well. We know that we're probably going to see those CBTs revert and probably see some of those modifiers revert as we saw pre-PHE, and we will see that post-PHE. Most of the commercial insurances are following some of that on the inpatient side. So again, this is what we're talking about now is inpatient, but we will see some consults still being doable post-PHE, et cetera, probably related to some of the inpatient behavioral health in particular. On the outpatient side, we know that home is now allowed as well as urban during the PHE. Also, the PHE is expected to continue at least through the summertime into the beginning of the fall, and then ramp down. The legislators just did a presentation that I was part of that they talked about how they're going to be ramping down the PHE. They won't see it completely turned off because they know that some people will still be concerned about going to their doctor even after we have vaccines and even after we have widespread vaccination. We know that there are some telephone codes that you can utilize. There's the addition of audio only option, which is great. You can just utilize the telephone, although we don't expect telephone only codes to have a high reimbursement, just as you would. We see video visits being more effective and more reimbursement over time, place of service codes, et cetera. And then don't forget your facility charges, right? During the PHE, you've got a couple of codes there to utilize for your facility charges. Don't miss out on those. I talk about this all the time to people. If there's a code for CMS, use it, because if we see data being reported out from CMS and we look for different codes from CMS, they might say, well, we have a code, and you haven't utilized it. For example, in remote patient monitoring, we see some resistance to utilizing the remote patient monitoring and billing for RPM. but go ahead and do it because we don't want CMS to see that there is not usage of the codes that they actually have put forward. And then post PHE, we know that we'll probably see modifiers reverse. We know that the eligible geographic requirement will revert unless Congress passes that legislation that we are hopeful for, but not likely. So what we do see is CMS trying to shift things out of a definition for telehealth and put it into sort of regular space. So in the way that we saw CMS changes that I mentioned just a moment ago, some of those were sort of defined in a way that were not going to be under a telehealth umbrella. And the same thing is true for remote patient monitoring. That is called remote physiological monitoring from CMS, because remote patient monitoring is under telehealth, but remote physiological monitoring is not. So I call that name trickery that CMS is doing, trying to desperately to try to pay for telehealth visits in any way that they can. We know that the home may continue to be valid for originating site for example, under the dialysis, home dialysis, and certainly for substance use disorder treatment. I should say that I'm happy to take questions throughout. So if there are any in the Q&A, I'm happy to take those, and don't forget to ask any questions that you may have. Even if I can't answer them on the fly, I'll certainly try to answer them even post and send you an email. This is a pro forma that we've done for an organization for behavioral health. Now, granted, this particular organization is a high volume organization. However, what's important to see is behavioral health and mental health services of all kind are very profitable. It's very easy to use telehealth in a behavioral health setting, both for medication assisted treatment as well as therapy. And as well as crisis intervention in the ER. I know we've got some clients that are managing patients in the ER, unfortunately, for 2 to 3 weeks in some cases, which is awful, but it's the reality. But what's important to see here is the total operating expenses pretty much stay flat in a behavioral health scenario when you're doing a telehealth service, but the operating and revenue, program revenue increases over time because your population increases, you see more and more patients of your population, and that service becomes more and more known. So over time, that program becomes more and more successful. So consider doing a behavioral health service if you aren't already, and if you are doing a behavioral health service, expand that service as much as you possibly can. Some barriers to adoption still exist. We know that licensure is still an issue. We still have cross-state licensure challenges to deal with, although the medical physician compact is definitely moving us in the right direction. And we see in some cases now they're starting to say that there's going to be a penalty if you're not part of the medical licensure compact. So watch that space. Reimbursement, we'll see how this moves forward. CMS is still, you can see, sort of trying to pay for telehealth. Broadband connectivity, always a challenge. Please try to do what you can to advocate for broadband connectivity in support of the bill that is currently in the House related to expansion of broadband services and utilizing that as a utility. And of course, security and privacy concerns. We know that the DOJ has recently prosecuted over 345 people in a broad fraud claim for telehealth. This isn't good for telehealth, but it just shows you that there are bad actors, whether they're in face-to-face medicine or telehealth. It's at the same level and same percentage, essentially, of crime that we see in face-to-face versus versus telehealth. So privacy concerns, regulatory and security concerns, definitely out there. Just keep in mind watching out for your patient privacy when you're doing a telehealth visit. There are some tips that you can do, some things to cover your backgrounds, making sure you're in a private space, etc. I have a whole presentation on doing the right thing when you're doing provider etiquette and patient considerations in a telehealth space, and I could certainly talk about that at a later time to anyone who wanted to ask me individually about that. This is a water tower where they are putting up repeaters. They're putting up, and I'm not technical and I don't get up on top of those water towers, so I'll probably use the wrong terminology. They're using some microwave technology and broadband technology to extend the Wi-Fi across that region. This is a way that many rural organizations are utilizing. They're utilizing this method both on water towers, on abandoned TV towers, and on schools to be able to extend their broadband from the hospital out to the community, so that you can do telehealth visits no matter where those patients are located, in a rural or an urban area. So consider this. There's some funding also available to pay for this type of program. So keep that in mind. And if you need more information on that, I can certainly provide it. But there are some patient technology challenges as we implement programs where we're trying to get as many visits as we can and reimbursement as we can, and to reach those patients to improve access to care. But we have patients that have data limits. They have connectivity challenges. They don't necessarily have a smartphone capable of doing a video visits because of their poverty level. We know that they don't necessarily want to add an app to their device. Who wants a hospital or healthcare app on their phone? You may want one that shows you how many steps you took, or how much body fat you have today, or how much water you drank, but you're not going to use that every single day. So many people don't want an app added to their phone for you. So consider that when you're thinking about the types of solutions that you may be purchasing. They may have varied technologies in the type of phones that they have, or smart technologies. What do you do when there's an emergency during a visit? Make sure that you've got that defined in your processes, that you have some kind of definition of what happens when there's an emergency from the patient. You're not in the same location, so you can't call 911 from your location. They'll come to you. You need to call 911 from their location, because it's different. It's a different 911 wherever those patients are. And then keep in mind, what about additional caregivers or translation services when you're picking those softwares? So you need a physician, a patient, a caregiver, or a family member, and a translation. So do you have the need for 4 different people to be able to be part of a virtual visit? Can that technology do that for you? So a lot to consider there, so you can maximize your telehealth visits. But remember, we talked about having ants and picnics. So the performance metrics are really important to us as a company. We drive towards that, improving quality of care, improving access to care, and figuring that at the end of that, reimbursement and money will come, because we can demonstrate that we've done a better job in the types of services that we're providing. So for example, look for metrics that you're already tracking. So if you're already tracking, and you probably should be in the hospital, you should be tracking this, not probably, falls, for example. Anytime that you see a telehealth program like a telesitter, improving the amount of falls that you have in your organization, that's a win for telehealth. Looking at some of the other value-based or quality reporting systems for pay-for-performance, measuring against those. What about some of your physician quality reporting for the PQRSs and the MACRA and CHIP reauthorization? This is an important element for you to be able to measure the requirements in those programs against what you are currently achieving, both in a face-to-face and in a telehealth. So comparing your face-to-face and your telehealth visits, that's a really great way to see how effective you are. And of course, your HEDIS scores. One thing I wanted to, and I love ARC, take a look at the ARC indicators. We put the references on all of our slides, so you'll see that on other slides that I've already shown, but in this case there's a lot of different places to look for quality metrics. But one of the things that we see today, for example, is Press Ganey has several questions in there for telehealth. Ask Press Ganey to add that in if you've got that for your patient satisfaction system. If not, you may want to look into that, or some of the others. They're definitely moving forward and having some telehealth in there, regardless of which one you're utilizing. For virtual visits, the virtual visit performance metrics, if you're utilizing those, and you should be taking a look at them, both on the HEDIS utilization, mental health utilization, looking at preventative care. Have we been able to get more patients in for vaccines? Have we been able to get more patients in for breast cancer screening? Have we been able to move people forward in tobacco use and other types of preventative care and screening tools and screening clinical services, as well as controlling their high blood pressure. So have we been able to take patients and move the needle on our face-to-face visits versus our telehealth visits? So again, it's a comparison between face-to-face and your virtual visit. Now, a lot of times you'll find that telehealth is the only reason that that person got any care, because they might not even show for visits, or maybe they've never even come in for a visit. They're not able to do that because of transportation or other issues. And so now you've been able to reach patients as well. So there are lots and lots of reasons why, and you can pull the data related to that as well. Why would this patient have been able to see a doctor without this telehealth visit? And you can start to demonstrate that in surveys, and you can report that to help you with your sustainability of your program. Because we will continue to go, at some point we'll be going back to where we were, hopefully not 100% where we were on telehealth. Hopefully we'll see, and as the ramp down happens with the PHE, just an FYI, the legislators have told us already that until the PHE is almost going to be over, that's when you'll see Congress act, unfortunately. So don't look for big sweeping changes for payment systems in the first quarter of 2021. Look for those more in the summertime of 2021, and hopefully we'll see something coming out from a legislative perspective. This is some ARC composite measures that I think are really great when we look at some of the patient safety measures, some of the quality improvements, and some of the prevention metrics as well for chronic conditions. So you can use telehealth as a bridge. I know you thought you weren't going to see actual ants. I know these are kind of gross looking ants too. You thought you were going to just keep on with the cartoon ants. I thought I would shock you here at the end. But what's important to see here is that there's an ant in the middle that isn't actually touching anything except another ant. And he's transferring from the leaf over to that other space over there, which I can't really tell if that's a rock or another leaf or even a water bubble. I'm not really sure. But whatever that is, they're transferring and using themselves as a bridge from one thing to another. And that's what you need to use telehealth for, as a bridge. Take telehealth and bridge your capacity. So build capacity in your organization, bridge to clinical services that you don't currently have in your organization. So for example, take a third-party company to help you with a service that you don't have. And you might say, well, I don't want to do that. That's not in my culture of my organization. I understand that, but maybe do it for a small period of time to build that capacity so that you can then hire someone to be able to do that. It's sort of a chicken and egg. You're building an opportunity for you to bring on someone else in the future. And telehealth can build capacity in your existing schedule. The average visits for telehealth are somewhere in the neighborhood of 7 to 10 minutes. For a patient on a face-to-face visit, it's somewhere in the neighborhood of 120 minutes. So the savings of time, particularly for the patient, is extreme. And for a clinician, it's also much better. 21 minutes for an average face-to-face visit versus in the telehealth visit, it's usually about 7 to 10 minutes. And then you can use them on the bundle payments, as we talked about. Reduce your overhead costs for real estate. Get a smaller footprint. Can you do this at home? Sure you can. So the docs potentially can be working from home. There's some I may have already talked about this, but there's some things that you can add for screening behind the doctor's virtual backgrounds are not really good for patients. They look a little bit weird, and they're not really sure what's behind that virtual background. So if you can use an actual background, that works better. It looks better. It's more professional. And they have them where you can put them on the back of your seat and they cover the whole viewable area. So look for those on, I think you can buy them on Amazon. And you can use them for provider specialty services that you don't currently have. Reach out to those organizations that have additional capacity for dermatology or cardiology or other nephrology or any of the pediatrics types of services. I know the pediatricians aren't really that keen on doing telehealth, but there's lots and lots of studies that are being done right now with Sprout, which is a pediatric research center, and they're showing how we have benefits for patients, particularly those 2 and over, where we can utilize telehealth. And even for the teenage folks in the behavioral health space, they love it. They love talking on FaceTime. This is their everyday with their friends. Or we've seen for those that don't want to communicate directly, they love to text. They will message it. They'll do it in the chat. So lots of different methods that you can utilize to be able to access those patients and give them more care. And then utilize additional services, external services, to learn how to do it, copy from them, and then operate independently. So utilize those services as a bridge, build your own capacity, and then become even more independent and stronger because of that partnership. So this picnic doesn't have any ants. So we have a nice clean picnic. We've been able to put together both our revenue cycle, our reimbursement, and our quality to merge our business together for telehealth and create a strong and sustainable program. Can't have one without the other. You can't build a program just on volumes. If you're doing that today, just grinding on, well, we should have 10 visits today, 20 visits tomorrow, 15 the next day, whatever, I can tell you that your docs are going to rebel against that. So don't look at just volumes. Let's expand. Let's look at quality of service. Let's look at how we can access more patients. That's how you reach those docs. That's how you create a good program. And that's how you create something that's sustainable for your organization and for your community. Thank you to you, healthcare heroes. You're doing this every day. You're in the trenches. You're taking care of patients. I really appreciate the work that you're doing. And please take care of yourselves. Make sure you're staying healthy. Many of our clients are getting vaccines this weekend. So hopefully your organization will be getting one soon if they're not already. And we appreciate everything that you're doing. Hang in there. If you have any questions for me, please feel free to email me or call me directly. You can leave a voicemail, or I may even be able to answer the phone sometimes. But you can also reach our website at blue-cirrus.com. We have a lot of information on there in our knowledge tsunami, where we do webinars every single month. We have articles, and we have our podcast or our radio show that we do each month. And again, as I said, go to the UMTRC and utilize their data, their information and their data that they can share with you. CCHP, all of the resource centers across the country do an excellent job. They work hard for you and your organization. So take advantage of the help that they have to offer. And thank you so much. I'll take some questions now if anyone has any.
Thank you so much, Michelle. You're just a wealth of information. As we're waiting for questions to come in, and again, please use the Q&A function for those. I have a couple of questions to get us started. I love that you mentioned the Fair Health website, because I found it very interesting. And you looked at the different diagnoses year over year, and I really expected there to be more differences than what we've seen. But we do know that behavioral health is one of the easiest types of telehealth services to start with, since you're not worried about patient vitals.
Absolutely. I love that website, and you can drill down to the region level. So you can go anywhere within the regions of the country. Mm-hmm. And what I found interesting, and I mentioned that, was the acute respiratory illnesses. We're not seeing that via telehealth, which I expected that we would, right, given COVID, but we're not seeing it because we don't have really we haven't seen heavy flu right now.
Right, absolutely. Absolutely. And then you mentioned telesitter programs. I'm only aware of one in our region, but I have to think that there've got to be more. Can you expand upon what a telesitter program is, if people haven't heard about that?
Sure. It's a great program in a hospital system. It's not unusual for patients that are at fall risk or are a risk in general. So a good example is a patient who may be a drug addicted patient, and you're worried that they might either self-harm or they may actually use drugs inside of the hospital, which unfortunately has happened in one of our clients. But where you currently would have an actual sitter in the room, and the hospital would pay for that, right? And you're not billing the patient for it because it's that's something that you're requesting, not the patient. So there's a sitter in the room to help stop the patient from falling and help them in case they were trying to get out of bed. Obviously, there's technology as well that helps warn, but this is a fail-safe with a lot of folks that utilize an actual person in the room. Secondarily, for those that you're worried about self-harm, keeping an eye on those patients, having the person in the room. So anytime you have a person that you're paying for in the room, that's expensive. That's something that you're paying that's on top of the services that you're getting paid for. And the telesitter program is actually a hub and spoke model. So they'll have a camera in the room. And that camera has, in some cases, stick technology. So stickman technology, I think that's how you call it, right? So like a hangman. And it will show the patient in the bed, and it will show whether or not they're moving around a lot, and it will alert someone. So they can do up to 25 beds with one monitor with most of these programs. I have some names, but I don't want to name it or show any bias to any of them, but most of them can do up to 25 beds. So you have one sitter monitoring 25 beds, and they have alerts associated with them based on the stick figure technology and how much they're moving, where they're going, and tells them that, hey, they're potential for, you need to pay more attention to them. So that allows that person who's the sitter, who then you can get the cream of the crop of your sitters, and then you can move directly into that patient's room and look and see what's going on. Button in and say, can I help you with anything? Are you okay? And the telesitter can actually call the nurse's station, contact them either through other technologies, and call the nurse themselves directly and call them into the room to stop anything from happening in the room to help keep the patient even more safe. And it's a win-win from a dollar figure. So you're already paying for those sitters. It's huge cost reduction, because the software is not that expensive relative to what you're paying right now for telesitter. It's a no-brainer. Your nurses will love you if you install telesitter. It's a great program.
Yeah, absolutely. Thank you very much. We got some things in the chat here. Hang on. I am curious how to build a team as we look to build a robust program post-COVID. How many team members, specific roles, etc., and any resources or recommendations?
Yeah, good question. So it depends on how big your organization is, but I'll say that I have a 25-bed hospital right now that we're working with, and they don't need a telehealth director for that size of a hospital, 25 beds. They really need a telehealth coordinator. They need someone to project manage, or a clinical program design person. The typical industry term is a telehealth coordinator, and that you should be able to find some like HR benchmarks for dollars in your region for that type of a role. That's a standard term in the industry. But if you're in a hospital that's 400 or 500 beds, you're going to need a director to help you define strategy. You're going to need another person, usually at least half time, to be able to do your implementations, your program design, and moving your programs forward, collecting your reporting structure, and going out into the field to show people how to do telehealth and help them to get adoption. So as you get larger, you need that. And I would always say, I didn't include this in my statement just a moment ago, but you've got to have IT involvement. We don't advocate Luceris for telehealth to be housed in IT. Although some organizations do that because they have especially at the beginning, IT has a history of doing implementations and doing good jobs with implementation. So it seems like a good spot to put in a new program. But in fact, it's a clinical program. So we always advocate for it to be in a clinical area, but you do need IT support. So you're going to need some kind of matrixed IT, whether that's a quarter or a half an FTE, to be focused on your IT telehealth. So watch that. With the smaller hospital that I talked to you about, the 25-bed, they probably only need about a quarter of time from an existing FTE. So just getting the CIO to be able to pull out some of that time for them to be dedicated to telehealth. And versus the larger health system, they probably need somebody that's dedicated to it. you've got to, the big thing about telehealth, you've got to have support, because if you don't get the visit up and running technically within a couple of minutes, those docs are going to revert to a regular face-to-face visit or a telephone visit. So you've got to make your support very, very quick.
Yep, absolutely. Thank you. Got a couple questions about slides, and yes, we are recording today's event. It will be posted to our YouTube page. Michelle has agreed to share her slides with us, and we will post those on our website under archive webinars. Once we get all of that posted, we will send out an email and let everyone know. And then as we start to close here, I'm going to put in the chat a short survey. There are 4 radio button questions. So a very short 1 to 2 minute survey. And as a federally funded organization, we always have to provide information back to our funders. They like to see what we're doing, and there's a place for you to suggest future topics and make sure that we're doing a great job. So Michelle, I want to thank you once again for being with us today and presenting this information.
You're welcome.
Yeah, just a lot of stuff that's going on. You know, this huge tsunami of interest in telehealth that we've experienced this year. It's kind of the silver lining in everything with COVID.
Exactly. We've experienced 10 years of growth in 6 months.
Mm-hmm.
So we've all been doing things, learning new ways to work, and also being stretched to the very edge of our capabilities. So take care of yourselves, everyone out there. Make sure you take time during, especially during the holiday period here, to have some balance of family and work. And if I can help you at all in the future, please don't hesitate to ask Becky and the UMTRC and everyone from the Rural Health Authority for Indiana Rural Health. Thank you so much for having me. I appreciate it.
Absolutely. We do have one last question that just popped in. The Clybourne bill that you mentioned, do you know the name of that bill or the number on that bill?
Let me look real quick. I don't off the top of my head, but I can find it very quickly. Let's get it. Hopefully you're not seeing me search.
No, we're still seeing your slides.
Okay, good. For you. It is HR 7302.
HR 7302. Thank you.
7302. Yep. Majority Whip introduced it in July. It's part of the Rural Broadband Task Force for affordable internet for all.
Okay. All right. And with that, I want to thank everyone and have a great rest of your day, great weekend, and happy holidays.
Thank you.